Welcome to the Texas Public Policy Foundation Healthcare 101, learning from healthcare reformers operating in the state and nation discussion. If you are sitting in your seat realizing you didn't mean to come to an hour-long dialogue about healthcare policy, it's too late. The doors are barred, and our impeccable front attendant Miguel has orders to tackle fleers on site. For those that know they're in the right place, you may be asking, why is TPPF holding a panel about healthcare amid big initiatives around school choice, immigration, and other pressing public policy issues? My answer is that the outcomes of other public policy fights can only be enjoyed if we can afford the healthcare services, knowledge, and medication that quite literally keeps us alive and healthy. The fight to make Texas the freest place in the world, and the fight to keep our leader, a leader among nations, requires us with the utmost diligence to address all domestic issues, including the black box that is our healthcare system. To help us make sense of what's going on in the world of healthcare, I have assembled an all-star panel of the greatest healthcare reformers operating in the state and nation. See that, David? I used it in a sentence, very clever. So, right here, without further ado, I have the Honorable Representative James Frank from District 69, who also serves as the chairman of the House and Health and Human Services Committee here in the Texas Legislature. Over here, we have David Ballot, healthcare expert, founder and CEO of Healthcare Finance Specialist, and my predecessor for the Ryan Healthcare campaign here at the foundation. David is the one who thought it was a good idea to hand me the keys to the Cadillac, so if you don't like me, blame him. Over here, Charles Miller, Senior Policy Advisor at Texas 2036. He is a seasoned thinker, diehard Texan, frequent coalition partner, and overall, great guy. And with us from Washington, D.C., Michael Cannon, the Director of Health Policy Studies at the Cato Institute, also an author of a recently minted book and a thought-provoking and minted book called Recovery. If you want to get understanding why our healthcare system is so broken, and more importantly, what are some of the out-of-the-box solutions to address it, I encourage you to talk with him after the show. I have all these notes. So, gentlemen, there's been amazing legislation that passed this last regular session. Thank you, Representative Frank. Texas and the country still finds itself dealing with a myriad of healthcare policy problems. For starters, our country annually spends over $4.3 trillion on healthcare. For you economists in the room, that's about 18.3% of our GDP. Number two is that most self-report surveys show that 68%, or 7 out of 10 Americans, have said they put off medically necessary care, citing they're fearful of high cost. Employers and families are paying on average $22,463 a year on their insurance premiums alone. That does not include deductibles or other cost sharing. Many states are dealing with physician and nurse shortages. Texas in particular stands out with 64 counties not having a single hospital, 159 counties do not have a single obstetrician or gynecologist, and 25 do not have a single primary care doctor. The Texas Health and Human Services Commission predicts our state will be short approximately 10,340 doctors by the year 2032. And the independent practice of medicine is endangered. Nearly 7 out of 10 doctors are now employed by hospitals, insurers, or private equity companies. Hospitals are consolidating at an unprecedented pace, which is problematic considering there's a large body of literature noting that private health insurance premiums, as well as prices, tend to skyrocket after a merger or when a hospital doesn't have any competitors in 15 square miles. And probably the most simple yet egregious, nowhere else in American history has there ever been so many middlemen administrators getting in between the patient-doctor relationship. Whether it be dealing with erroneous bill coding, finessing an insurance prior authorization, browsing for shoppable healthcare services, or selecting coverage that works best for them, many patients don't know where to turn. These trends are tragic and unacceptable. Our country and Texas deserves better. So, audience, the gentlemen on stage represent their own opinions, organizations, and respective stakeholders. I say this because you will notice that we may differ in contrast on our approaches to addressing healthcare policy issues. However, despite our differences, everyone on stage knows that it takes cooperation, alignment, and a village to effect positive healthcare policy reform. So I charge you all, as we talk, please listen to the trends of agreement between the panelists, because it is in that agreement where workable, quality, and impactful healthcare reform can take place. So all that said, all that monologue, this is a softball question for you all, gentlemen, so feel free to jump in. But this is an important one, by the way. Why have you all dedicated so much of your time to addressing healthcare policy? why get the start in your career to do this great stuff you're doing?
Me to start?
Yeah.
Can everybody hear me? I came from industry. I'm a child of immigrants. I was supposed to be a doctor. It didn't work out for me. But I loved the hospital. I worked in them starting at the age of 15, and I was very close to patient care. As I realized what my skills were and where my proclivities were, it was more on the administrative side. And as I worked my way into administration, I still saw myself as somebody who was delivering or being a part of creating an environment where patients were being taken care of. I've worked in the ERs, I've worked in just about every department in a hospital, and I've seen where people are suffering. I was once told that a hospital is one of the only industries, if not the only industry, where the customer comes in a vulnerable state. And so that was something that I held precious. And I always think in terms of what's best for the patient. How do we empower them? How do we engage them? How do we care for them? And as I moved into policy, I never lost that. So I'll stop there and I know we got a lot to talk about, so I'll end it there.
Charles.
I started asking the question why things were the way they were, and I never really got an answer that made sense. And I kept asking that question and kept asking that question, and then I had a career. I am a recovering attorney and got exposure to the irrationality of healthcare prices in that field through litigation defense, where these issues would go before judges and juries, and it was one of the most heavily litigated issues, and nothing made sense. And it made no sense for so long that I said, I want to stop doing this. I want to start working in the policy world to help try to start make sense out of it.
I got into health policy because that's the job that was open. I was a young libertarian who wanted to work for human freedom, and they offered me that job, and I said, I can do that in healthcare. I can fight for our healthcare rights, like the right to make our own health decisions. And I'm very glad that that job was open, because now 28 years later, unfortunately, there's a lot of work to be done. But the message about how freedom, individual freedom, the freedom to make your own health decisions, can make healthcare better and more affordable and more secure is a very powerful one. I think we've got a fantastic story to tell, and I'm really glad that that accident happened.
Probably two different ways. In my day job, I'm a state legislator. I spend most of my time on my day job. How I afford to be in state legislature is I'm in manufacturing. I've got a couple hundred employees, and it just continued to be amazing to me how much money that the employees had to spend to get health care, and how basically how much they were overpaying. I always say we literally are paying twice as much in this country for the same results. And we wouldn't do that in any other area, but in healthcare, we just kind of ignore it. And it just bothered me that the money that we were putting in and the money that the employees were putting in, and most of our guys, they make good wages, but not ridiculously high wages, right? How much it was hurting their quality of life compared to what healthcare would cost anywhere else. Then you get in the legislature, and my committee's got the Medicaid responsibility. And so I started looking at it that way, and looking at how much healthcare was essentially pushing everything else. Every other priority in the state was getting pushed out because of the exploding healthcare. And then, anyway, so it's really just, it seems really unfair. In fact, David, I'll segue on something you said. People come into hospitals at a vulnerable state. It is the area that you need the most ethics in your pricing, and it is the industry that has the absolute least ethics. I mean, literally less ethics than any car dealer. The worst car dealership you've ever been in would make most hospitals look awesome. Like, it's just the grossest thing. And I mean, pharmaceutical companies, all of that, it's like this black box, and people, as long as somebody doesn't know, and as long as they're in a vulnerable state, we're going to jack the price up absolutely as much as possible, and we'll blame it on something. We'll blame it on Medicaid underpayment, or we'll blame it on something. But it's not me. I'm just going to, so anyway, it's just been out of general frustration.
A lot of frustration. I can relate to that. Also for myself, I actually got into the healthcare policy fight because I was working over at Providence Health Emergency Department, and I was doing mental health evaluations with PsyDs. And I think the story I tell people is that I had a patient who jumped off their roof. Cops brought them in. I'm like, oh, okay, like they're comorbid with many different disorders, have long family history. This is not good. We definitely want to involuntarily commit them, but we don't have a psych ward, so we had to refer them to an outpatient facility about 10 miles away. And as we were discharging them, I remember a nurse coming up to me and being like, oh, it's like the 9th time I saw that person. And I'm like, I was like, when? Like, she's like, this month. And I was like, whoa. And I went to go over and looked at some of his notes, and I was like, oh my gosh, he's on Medicaid. We're subsidizing him to not get care. And when I realized the administration of healthcare hurt people more than their own ailments and illnesses, that's when I kind of realized what needed the most curing, and that was more the macro healthcare policy problems. So can definitely relate to all you gentlemen. So getting into like the meat and potatoes here, I want to ask you, in your own words, what would you say the largest healthcare issue is that we're facing as a state in Texas, or more generally the nation? Anyone wants to jump in first?
May I? There are so many. I think anybody who says that they have a solution for healthcare doesn't understand that there's a multiplicity of problems that need to be addressed. There is no one single solution. This idea of Medicare for all or single payers is ridiculous, because there is no one solution. However, one thing that needs to be held as a critical component of all the solutions that we propose is the patient needs to have some agency. Healthcare at its root, its basic building block, is the doctor-patient relationship. And that has been fractured. And there have been a lot of organizations that have injected themselves in between the two primary stakeholders. And they've relegated medical professionals to very well-paid data entry clerks sitting in the corner, helping their entities bill as high as they possibly can. So we need to have them start facing the patients again, touching the patients, and reestablishing that relationship. 7-minute visits they're not conducive for good healthcare, good diagnosis, good therapy recommendations. So that the doctor-patient relationship is critical.
Tanner mentioned my book, which is available in the lobby, by the way, titled Recovery. And one of the charts in that book, I think, highlights the biggest problem, not the only problem, and a problem you can fix with one reform, but the biggest problem in the U.S. health sector. It uses some OECD data to compare the United States to other countries. But instead of comparing the United States to other countries on spending levels or even per capita or per GDP spending levels, what it does is the OECD collects data on what share of health spending in a given country does the government control and what share do consumers control. What share is voluntary spending and what share is compulsory or government or otherwise compulsory spending. And you would think from a lot of the rhetoric in our debates over healthcare in the United States that the United States would have a huge share of voluntary spending and a very small share of government spending, because everyone likes to say we have the largest private market in the United States. A lot of people say the United States health sector is a free market, and that's why we have all the problems that we have. Incredibly high prices, poor quality care in many cases, a lot of people who cannot afford insurance or the care that they need. But what the OECD data show is that the United States ranks very high in terms of government control of health spending. About 85% of health spending in the United States controls directly, money that government controls directly, either by spending the money itself through programs like Medicare and Medicaid, which is about 50% of health spending, or indirectly makes it compulsory by saying either you let your employer control a huge chunk of your earnings and choose your health plan, or else the government's going to penalize you by making you pay higher taxes. That's another 35%. So 85% of health spending in the United States is spending that the government controls. That is the 8th highest share among OECD nations. And the highest is, I think, Norway, or it jumps around from year to year, but the highest share is only about 87%. So we're within just 2 percentage points of the most government control when it comes to healthcare financing. And that is 85% is a larger share than in the United Kingdom, which has an explicitly socialized health system. It is a larger share than in Canada, which has an explicitly socialized health system. And it is larger than the OECD average. That, I think, is the biggest problem with the U.S. health sector, because it doesn't matter whether you organize that along, corporatist principles or democratic socialist principles or communist principles. It doesn't matter. Any economic system is going to serve the people who control the money, and the people who control that $4.3 trillion that we're spending on healthcare are not the consumers. And that's why prices are outrageously high, because hospitals are engaged in this game of price discrimination where they try to get the highest possible price they can out of these huge third-party payers which the government encourages us to use. And the patient who's paying out of pocket, well, they're not a big player in the game, and there aren't enough of them to make a difference. So they get gouged with these outrageous prices that we see in our hospitals. And on it goes, all because the wrong people control the money.
That was a very top-level explanation. I love that.
No, I think the biggest problem is the cost is too high, because that affects access. Because the quality, honestly, the quality in most of the United States is very good. Like, there's not many clinical problems. I'm sure there are some, but we get good care when we get it. It's just twice as expensive as it should be, which means, from an insurance standpoint, it should, instead of $22,000 for a family, it should be closer to $11,000 if we were paying. And most of that is because of the government. To your point, it's protectionism. Think about this. We don't allow importation of drugs from other countries. So we have drugs that are made in this country that are sold overseas for a third what they're sold here. If that happened with cars, we would go crazy. Like, if you knew that you were paying $60,000 for a car that somebody was buying $20,000 overseas, you'd be crazy. That was made here. But because we don't allow, that's pure protectionism. Do you really think Canada has are people dropping because of dangerous drugs? No, they're not. But it is protectionism. The other protectionism that happens is allowing all the mergers. I love the argument of economies of scale. Yeah, the economies of scale work great. If you have two hospitals, let's merge them together, because the economies of scale say, I'm going to make a whole lot more money when there's no competition. It works awesome. It does not work awesome for constituents, but it works awesome for the hospitals. It works awesome if you look the consolidation that has taken place in the medical equipment, all of those places. There's just, the money is all controlled by a few people, and almost all of that is by the government. It's too much regulation in some case, and the two places that should be working, FTC and FDA, are, in my opinion, complicit with the larger companies in terms of allowing them and almost encouraging them to control the market. But it's basically too expensive. The question hopefully we'll get to is, well, how do you push back on that, which there are ways to do it.
Everyone's right. It's the prices. Stupid.
Thank you, Charles.
They are too high, and there are two huge impacts for that. One is that a lot of people are skipping care because the prices are too high, whether they're insured or uninsured. Uninsured, 85% are skipping care because it's too high, and 65% of people with insurance in Texas are skipping care because the prices are too high. That's a huge problem, and insurance is not the solution to that problem, as we see from that. But the other part of that is that the overall expense that we're paying, whether it is through our government systems or through our insurance premiums, are also too high and unsustainable. So not only are we spending a ton of money, we're also skipping care because the prices are too high.
And I was just going to say, we don't even measure it right. When we have discussions like this, we don't measure the quality of care. We typically, when we get into policy discussions, we measure quality of care on whether somebody has insurance or not. So my employee that has insurance but can't afford to use it is counted as good. The person who has Medicaid but doesn't have a provider, they're counted as good because they have insurance. Somebody going in and get cash pay with a direct primary care and getting great care, they're counted as bad because they don't have insurance. Like, we're not actually even measuring in the policy discussions who's getting care or not. We're just measuring whether or not somebody has insurance, which, if anybody thinks insurance means you're getting quality care, I'm not saying it doesn't matter, because it does, but we're not even measuring the right things.
David, don't you have a phrase talking about access?
Coverage isn't care.
Why is that?
We've conflated the two. It's just what Chairman Frank just said. And when you hear a politician in D.C. talk about healthcare, let that trigger something in your mind. They're not talking about healthcare. They're talking about healthcare coverage. They're talking about health insurance. It's not healthcare, and so they deal in health insurance because that's what they can control, and they want to control the purse strings, and that's a way to do it. But no, me personally, I use direct primary care. I use a sharing ministry. When I go to a provider, I ask for the cash price, and it's typically 10 to 15% of what the regular charge is, and substantially less than what the insurance negotiated rate is. So I get a great deal, but it requires people understanding how to consume those services.
I just want to add on, and I think there's an important part here to be learned, that we improve what we measure, and we have great statistics on insurance coverage, and we don't have great statistics on whether or not people are getting the care that they need. As a result, when we look at what can we improve, we are improving what we measure. And so if we want to change these other things, we need to measure different things.
That's a great point.
That's a great point. So in the spirit of talking a little bit more about prices, Charles, price transparency has been a popular policy initiative since it was introduced during Donald Trump's presidency. We saw several federal rules and recent state laws come about requiring hospitals and insurance companies to post their prices and rates. While this is great, most survey data still shows that many Americans are still not interacting with those prices, probably to the structure of insurance that you described. However, I wanted to ask you, price transparency came with all these promises of lower premiums and prices. It's not being actualized. Can you kind of like to walk us through like what are the barriers? What's actually holding people back from using that data? Is it the culture? Is it tech? What is it?
So I think it helps to lay out a little bit of foundation of what price transparency rules have actually gone into effect. And there were two kind of broad avenues of it. First were these rules that applied to hospitals. The other were rules that applied to both insurers and basically anyone who provided insurance as an employer or coverage as an employer through ERISA. On the hospital side, hospitals were required to make these machine-readable files that listed all of their negotiated rates public. Compliance has been a bit of an issue. We're in Texas, I think we're about 2/3 of hospitals are mostly compliant, but that's better than it was to start. And insurers then also had to follow with making these machine-readable files transparent. I think it was a mistake for anyone who thought that those files by themselves were going to lead to this consumer paradise. They were not designed to be utilized directly by consumers. They were designed to be used by large institutions and large data centers to understand what's going on. The consumer side of things may be coming, though. The other side of these transparency rules is one that will take effect January 1 of this upcoming year, which will require insurers to post on a phone app or on their website provider-specific prices that are tailored to your particular insurance plan. So if you have insurance, you can log on, get a list of providers with the specific amount that you will pay for a specific procedure. That may be helpful. The downside, potentially, though, is that a lot of the research shows people just aren't interested in looking at these things. Some plausible explanations for this are that it's generational. We know that older consumers generally are not using these things, and it could be because they never learned how to shop for healthcare. There's a famous anecdote about the East Germans didn't know how to shop for jeans after the wall fell because they had never done it before. And there may be something to that with this older generation that was raised on this idea that you didn't shop for healthcare. You went, you did what your doctor told you, and insurance paid for it. Younger generations are more open to this, and so it may take time before they filter up through this more comparison shopping generation. The other aspect of it, though, is that in the past we simply haven't had good tech. Having the ability to use your phone to have the access to this information at the point of decision and have a real-time discussion with your doctor may change how those discussions are actually happening and may make these things more useful.
Do you want to jump in response to that?
So price transparency is a good thing. I'm skeptical of mandating it, though, because mandating price transparency when the consumer is not the one controlling the money is a little like trying to push rope. But you know what does deliver price transparency is a series of innovations that some employers tried that with an insurance feature that I write about in the book that's available in the lobby. There's even a chart in there that shows what happens when employers deploy this innovation. What happened was, and they deployed it when it comes to, MRIs, CT scans, colonoscopies, hip replacements, knee arthroscopy, shoulder arthroscopy. I'm leaving a couple out. Lots of different services. What they did was when they deployed this innovation with regard to all those services, prices not only became transparent, but they fell. And there's the most important chart that you've never seen in a health policy. It shows us how much prices fell for all of these services. Even at hospitals that had monopolies in their areas, those were the highest priced ones. For hip and knee replacements, those prices fell 37% in 2 years, $16,000 per procedure. What they did was they changed who controls the money. That innovation was really just less insurance. The employers and insurance companies said, we'll pay this much for all whatever the service is, and you can go to any provider you want. But if they charge you more, you're on the hook for the difference. And once it was the patient's money that was at stake, once they controlled the money that was paying for those higher prices that the monopolist hospitals were charging, they demanded price information and they got price information. And they didn't have to go to committee hearings and drag hospitals there and do all of these things you have to do when you're trying to mandate price transparency. And it worked better than those mandates do as well. It worked kind of like prices for hotel rooms. I'm staying in a hotel right now. I need to check the door. You ever check the back of the door to your hotel room? You know what's there? The government mandated prices or posting of the prices for the hotel room. If you pay those prices, then you need to talk. We'll talk after this program because those prices, even though the government's mandating them, they're not useful. Why? Because the hospitals. I always confuse hospitals and hotels.
If you're paying those prices, I have a consulting contract for you.
Right. The hotels set the price just like hospitals. They set the prices really high, but then competition bids those prices down because people who stay in hotels are spending their money more often than people who go to hospitals are. And we need the same sort of price sensitivity when it comes to healthcare.
Yeah, it comes down to, transparency is important, but it is only the first thing. In fact, if you have transparency and you don't have competition and you don't have customer engagement, which is what you're talking about, you really have to have all three. If you have transparency, but you only have one hospital to go to, right? Or if you have transparency, you have two hospitals to go to, but your copay, let's take just a knee surgery, all right? You got a hospital, one place is $20,000, one place is $40,000, but your deductible is $5,000. Do you care about shopping? Anyone? You're going to pay $5,000 no matter what. So you're going to go where you're going to go. You don't care. If all of a sudden you have some engagement and you care, then you all of a sudden shop, which is really what you're talking about. So you have, I thought that's what you were saying. You have to have, the customer has to be engaged and care in order to shop. And certainly it does it much faster. The market works much faster than the legislature.
And unfortunately, to change the money, who controls the money, there's not a lot that states could do there. You need federal action, but there are things that states can do to make prices more transparent because there are different types of price transparency. The prices for primary care and dental care in Texas are much higher because of protectionist regulation that prevents nurse practitioners and dental therapists from practicing and competing to bid down the prices for primary care and make transparent just how expensive those protectionist regulations are. And Texas is one of the worst states when it comes to those regulations. Down at the bottom, I think Mississippi does better than Texas. I've got some more charts in the book about that. Does better on liberalizing the regulation of these professions to expose just how much those regulations are costing consumers.
David, I bet you want to respond to that.
Well, I want to talk about the transparency of pricing. I understand what Michael's saying about the government being responsible for spending the money and how that money is spent. But on the ground floor, who's spending that money? It's employers and employees and people who are fully insured. If you have a $5,000 deductible, and according to AHIP's data, 80% of people never hit their deductible, you're a cash patient. So it's important to you to know how much a price is. It's important because one hospital that may have that's a part of a system that has the leverage to negotiate higher contracts, they have a CT for $1,500. This one is a one-off hospital. They were only able to negotiate an $800 or $900 one. By the way, I can get a cash one for $250. If you have a $5,000 deductible, where are you going to go? You even if you have to drive an extra 20 miles, you're going to go and save $500, $600. We saw price transparency work in the airline industry. Looking out into the crowd, many people aren't going to remember that you used to have to use a travel agency to buy an airline ticket. Congress mandated price transparency in the airlines, and then we started seeing innovative companies come in like Travelocity, Orbitz, Kayak, things like that, that made it easier. Now in healthcare, it's a little bit more complicated, which is why the next step for hospitals is to make their services bundled. Right now, if you go in, if you've ever seen an EOB or an itemized statement, you're going to see hundreds, if not thousands, of codes for, say, a knee arthroscopy. There should be a single bundled cost or price for a knee arthroscopy. I think that's the direction we're going to be going in, and that's going to simplify that process overall. Those are things that should happen for elective procedures, things that can be scheduled.
I just want to step in on this. I think there are some things that the state can do. I agree it's mostly federal, but I believe, if I'm not mistaken, the group that the employer you're talking about with those dramatic savings on the reference pricing was CalPERS, right?
Yeah.
So it can be a state government plan that adopts this sort of methodology, and that can have huge impacts and spillover effects. If I recall correctly, they achieved savings not just in their own plan, but there were spillover effects so that other employers were now paying lower prices because those providers were used to actually providing it. They started doing it for other buyers. That's a huge thing. The other thing the state can do is we do regulate the fully insured market, and there are things that you can do to recreate cash buyers. So we talk about most people don't actually hit their deductible, and therefore they should be cash buyers. But as long as you are in a insurance plan that has a network that controls every dollar, you are not a cash buyer. You have to go with the way that the insurance plan has negotiated that. However, Texas last session passed a bill, HB 2002, that starts to break that relationship. And basically what it says is that if you find a lower cash price than what was the overly arcane mechanism, the average
negotiated
rate, then you can go pay that cash rate and have that applied to your deductible, even if it's out of network, so that you're not put in that horrible choice of either making the intelligent decision to pay less money or pay higher so that you can count it towards your deductible.
Yeah, to give you guys an example, I had the unfortunate task to collect 300 cash prices and throughout several different city markets for a diagnostic colonoscopy, because apparently that resonates with certain legislators as a reference point.
I didn't ask you for that.
I didn't say you. I was just saying in general. It's also, we're talking Tennessee here. And so Tennessee passed HB 1213, and something really fascinating came out was that I kind of just looked at 2D map of Nashville and realized that if you call a provider right now and say that you're willing to pay out of pocket right here and now, suddenly the price drops. To give you an idea, I believe most average negotiated insurance rates in Nashville with like the three biggest plans were running about $2,400. And when I called people, they were offering $541, $1,000, $800, except for Vanderbilt, they were charging like $4,628, big teaching hospital. So the thing is, when you're in your, like, if you have like, as deductibles increase and you have cost like sharing responsibility, it totally makes sense to actually give a call and like start being like taking agency here and calling, because we all know that healthcare prices are made up. And so the question, Michael, I guess, is like, is this good? Like thinking through like, how can we think about price transparency and baking incentives for patients to get involved, right? Because this is new, because all of a sudden, if you don't have to pay $2,400 out of pocket when you have like a $4,000 deductible, and you can actually have that $541 counted towards that with no penalty because you just paid out of pocket. Isn't that a better world?
The $540 counts toward your deductible?
Yeah, it does.
Because of
it's lower than
2002?
Yeah, because
sorry, I'm using the microphone. So there are all sorts of strategies for trying to get prices down. One of them is consumers spending their own money. Then they care about the price because they get to capture the savings. When it's the insurance company's money, there are other strategies that insurance companies can deploy. One of them is co-insurance, so the patient's still on the hook for some of them, some of the price, so they care a little bit. Another one is provider networks, because if they strike a deal with certain providers that will steer our patients towards you, if you give us price discounts, okay, that can help contain prices as well. And there are others, the innovation I mentioned earlier, nerds call it reference pricing or reverse deductibles, but it's just, paying a flat amount per procedure or per service. And the patient's on the hook for 100% anything above that. All sorts of strategies out there that you can apply to all sorts of areas of medical care. And I'm pretty sure that if the consumer is the one controlling the money and can choose between this insurance plan that uses this strategy and insurance plan B that uses another one, and insurance plan C that uses a mix, and insurance plan D that uses a different mix, then the success of all those different strategies, the premiums for those plans is going to reflect that, and consumers will be able to make those decisions and essentially vote on which one of these strategies works best and which combinations work best. And we will get to something close to the optimal array of pricing strategies that strikes the balance that consumers want between low prices and access to care. And if we let instead say the government is going to mandate that the insurance company apply that person's out-of-network expenditure to their in-network deductible, and we're going to have the government mandate that providers provide transparency, we're going to spend a lot of time on strategies that are not going to work. Providers are going to end up capturing those strategies, and we're also going to get just fewer innovative strategies that insurers deploy and experiment with, because I have no confidence that the government is going to do that half as good as competition and patient choice would.
Representative Frank, you look apt.
No, I totally agree that the market is much quicker, much more effective. I probably disagree that it can be done through insurance companies because of the laws that are already in place, like medical loss ratios that give perverse incentives
It is a
for them
medical
to
loss.
want to. So they cannot innovate.
I got good news for you.
So they cannot innovate to make those lower prices. And so I actually think that, at least in Texas right now, unless there's some good news, that you really need to go around your insurance company to the extent you can. And it's really not, there are a lot of companies that are doing it, including we're doing it with our employees, where basically we are going direct contract with. One of the things I realized, the money that we were spending, when I look at the money we were spending for our employees and the money that they were spending, less than half of it was actually going to the drug companies, even hospitals, and I'm not a big fan, but to the people that are actually providing services for those. It was going to the middlemen. And by cutting them out, and then we essentially pay direct, and then we have a stop loss. We have what used to be called insurance. Like we have, I say we actually not self-insured, we have insurance with a $50,000 deductible, right? Like if we have a very big claim, then we pay it. But I'm not convinced with all the rules that are on the insurance companies, you're going to get innovation. I think the direct relationship between the patient and right now the businesses are forced to do it because of a government mandate that says that we're going to cover our employees. So
I think that
I want the good news from him, and then we go.
The good news is there is a way to get that innovation from insurance companies, because there are insurance plans in the United States that are exempt from those regulations you mentioned. The medical loss ratio regulation is one of the Obamacare regulations. There's also community rating, guaranteed issue, single risk pool, essential health benefits, and so forth. Very expensive. Make the insurance markets very rigid, so they can't experiment with coverage designs and these pricing negotiation strategies. But where insurance is exempt from those regulations is in U.S. territories. And it's a shame. The Obama administration exempted insurance in the territories from Obamacare's most expensive regulations, all the ones I mentioned. But you're mentioning protectionism earlier and how we can't buy pills from foreign countries. We can't even buy insurance from the U.S. Virgin Islands that doesn't have community rating laws. And prices for insurance in Texas would plummet if Texas legislators restored that freedom to Texas consumers and employers, because they have a right to trade with whoever they want. But Texas's protectionist health insurance regulations say, unless you comply with all of our regulations, you can't get a license to sell an insurance plan in Texas. But all the legislature has to do is say, you know what, we're going to deem as in compliance with all of our regulations any health insurance plan that the U.S. Virgin Islands issues, and all of a sudden the prices for health insurance for the majority of people in the Texas individual market and most Texas small businesses are going to plummet.
So that represents, the fully insured population is 16%. And actually, Texas Mutual, your bill, did that. Farm Bureau bill did that. So I think we're doing those things here in Texas, and we're seeing them actualize, and there needs to be a little bit of a ramp up. I think that what's important, and I wanted to say something about your company. I applaud you for actually walking the talk, because you've actually incorporated that direct contracting in your business. Right now, until we can get to the point where employees and individuals can have their insurance plans or their form of coverage, and be on the market for making the insurance companies compete. We have employers, and employers can make a lot of these decisions. They can change the market. They're choosing not to, except for very few.
Well, but in fairness, like I had a lot more data. Like I didn't go into it thinking I'm in the healthcare business. I ended up, knowing more because of the political. If not, I would have never had the tools and the knowledge to be able to make those decisions. Like you go into business, you don't realize that, oh my gosh, I'm actually also a healthcare provider.
It's a significant line item.
Fair.
It's a significant line item on your budget.
Yeah.
So you have to care.
The current system really requires that employers be doing something that is not their core business function, and that is manage a health benefit plan. And they are not in a good position to do that, but they do have a fiduciary duty to do so.
Agreed.
But they are put in a terrible situation of having to figure out a plan that meets everybody's individual choices. And generally speaking, they're not going to choose the most optimal scenario. And we see this even as regulated as the individual market is. We see that when people are spending their own money on these market plans, they are choosing much narrower networks than most employers provide. And some people say, well, that's a terrible thing. But it's people exercising their own choice in which plan they're choosing. And they are willing to spend less money in order to get that narrower network. That's an individual choice that if we had more of that individual choice coming through, would probably be yielding less spending by default.
Okay.
Though part of that is
Make us
because
pivot
Obamacare
here,
punishes
Michael
broad networks.
Cannon.
But
I'm going to pivot a little bit because we're about getting a little close on time for Q&A. So I wanted to kind of usher us to think about if you all had a magic policy wand that can make anything happen, what would it be and why? Because I want people here, when they leave this room, to be thinking about more than just single-payer Medicaid expansion or some other kind of lofty kind of government overreach and program to make sure that we have health benefits or health insurance or whatever we need. So what are some other things we should be paying attention to as patients, as Texans, as Americans, outside of those things?
magic wand,
Magic wand.
state or federal?
I want to challenge you to say state.
State. Okay. All right. Federal was easy.
Medical loss ratio.
State, I think it would be magic wand. It would be to eliminate clinician licensing in the state of Texas or in every state. Clinician licensing exists
Want to close out
ostensibly to improve the quality of care. It doesn't do that. It actually reduces the quality of care. I talk about it in the book. It's available in the lobby. And it increases prices for care so that instead of protecting patients, it actually makes patients worse off and adds nothing
We're short
to
on
the
time,
quality
Michael.
protections that would exist that do exist and would exist in its absence.
Magic wand for me is we would change the culture of medical, and that starts with the individual. It would be more individual responsibility. It would start with healthcare companies actually following their mission statements. I told somebody, I said, if we want to change healthcare, just have pharmaceutical companies and hospitals and insurance companies follow their mission statement. Like read it and then do it. Like, because it is the grossest behavior. I mean, when you look at the healthcare costs and you're going to a hospital and you go, they charge $26,000 for this person and $18,000. It's like they're just picking $4,000 for this person. They're just picking numbers up. We wouldn't do that in any other industry, but in this industry, that's what the culture has become. There is no culture of ethics in it. I mean, I look at that takes a big magic wand, but I think they can at least start with the individual and or companies taking more fiduciary responsibility.
All right, lightning round.
I would take the federal level, equalize the tax treatment between individual and group plans. And at the state level, I would actually enforce antitrust to prevent over-consolidation.
I have to give you a little bit of a background. When I was a young administrator, what a physician told me was, nothing happens in a hospital except for at the tip of a doctor's pen. It's important that we recognize that currently, as Tanner said, 70% of physicians are employed by hospitals, insurance, and private equity groups. That's in a state where we have Corporate Practice of Medicine Act, which means a non-physician cannot employ a physician. So there are all kinds of loopholes and just violations of the law that currently exist. We need an enforcement of that. And so my magic wand would be, we need to make sure that there are independent practitioners, medical professionals that are using their independent medical decision-making for the care of the patient, because I can tell you that these large organizations are mandating and requiring certain behaviors and referral patterns that are driving up the cost of healthcare and decreasing the quality.
Awesome. So we're going to shift over into Q&A. I have my awesome events team, Clint, over there passing around a microphone. Just as a reminder for you all, this is a Q&A. In order to get an answer from our panelists, you indeed need to ask a question, not a monologue. And usually you have to end it with an inflection at the end of your voice, signaling there's a question mark. So thank you.
Hi, my name is Dr. Cliff Porter. I'm a direct primary care physician. So thanks, Chairman Frank, and thanks, David, for the idea to do this. It is quite complex, and so maybe you can help unravel a bit. The corporate practice medicine, the vertical integration, the antitrust aspect seems to be very much connected. A lot of that's at the federal level. So I see the corporate practice medicine all the time, and I'm independent, which is so much better. But I'll see the vertical integrations. So I worked briefly at Care Now Urgent Care, which is owned by Hospital Corporation of America, HCA, which owns St. David, and they intentionally lowered the capability of the urgent care clinics, and then told us to refer patients if we couldn't do anything to them to the ER, so you're getting hit with double co-pays. How do we do that at the state level?
David.
How do you do that?
How do you?
How do you prevent that?
Yeah, how do you overcome these problems with vertical integration and the corporate practice medicine?
A very easy question.
I'd like to hear Charles's. How do you do this at the state level? Because I actually was try to get money in to do, because I do think that consolidation is a huge thing. The FTC is completely absent. I mean, they are not preventing this. I would love to do it at the state level. I looked at trying to get more money, and well, never mind. I'm not going to get into that. But how do we do it more at the state level, Charles? Because I'm there.
I think step one is we actually have to know who owns who, and we are lacking in many cases that data to see who owns or controls the affiliated providers. And this gets to the vertical consolidation issue. In many cases, we have primary care practices that are owned or controlled by systems, and it's not very apparent. And this is problematic both at the patient level, in that you don't necessarily know who is ultimately making that decision, but it also has problematic market issues.
This is where you go into I said the culture thing, and I kind of mean that, like almost making people embarrassed about what they are doing, like challenging them and saying, how do you find this ethical at all, what you are doing? Now, you know what I'm saying? Like, this is a medical professional in a company that is doing something that is clearly just to basically rape and pillage somebody in their like, how do we do that? Well, I mean, I watch people on hospital boards that are drinking champagne and caviar and all excited about it. I'm like, you guys don't even understand what you're doing to people out there. And unless we can change the culture, because every law that we pass, immediately the enforcement of the law is so hard, because this group is making billions of dollars on something and has tons of lawyers. So even trying to enforce a rule, if I could get a rule that said that is illegal, if we could ever get it passed over the lobbyist, the enforcement mechanism would be really hard. Who's going to enforce it? Our AG, it's so hard to enforce. That's why the culture, if our culture is, as long as it's legal, I will screw the patient as bad as I can. If that is the case, then we are lost. That's why I'm like, it has to be cultural. I know there have to be laws, but it also has to be people in those meetings basically calling a spade a spade.
There are two.
Go for it.
There are two things that are allowing that situation to happen. One of them is price insensitivity on the part of the patients. No way the patient would allow that to happen to them over and over again, at least, if they were the ones on the hook for the extra spending at the emergency room. And I think the series of experiments that I mentioned before bear that out. They are really, really price conscious, and they won't put up with that. The other thing is protectionist legislation that protects those hospital systems from competition by other systems that don't pull that stuff, not because they're any less greedy, but because they operate under different incentives. So if you had a hospital system that was not just inefficiently vertically integrated like that one, but efficiently vertically integrated with that operated on a prepaid basis. And what I'm thinking about here is a Kaiser Permanente type system. Kaiser Permanente would never do that, because it would cost Kaiser money to send someone to the more expensive facility. They want to deal with everyone in the less expensive facility. But you know why we don't have health plans that operate under those incentives in most states, including Texas? Protectionist legislation, and you might not like it, like clinician licensing. Clinician licensing is the main reason why we don't have integrated health systems throughout the United States. Corporate practice of medicine laws also prevent integrated systems like Kaiser Permanente from providing dimensions of care that the rest of the health sector is lacking. You want to know why medical errors are so high in the United States? Because providers can externalize those costs. Kaiser type plans internalize them and have incentives to eliminate them that other providers do not. You want to know why you don't have electronic health records? Kaiser
make
has
this a
been
little
using
more
those since the
concise?
1960s. So, but also health insurance regulation blocks competition from those sorts of health plans. On down the line, we have regulation after regulation put in place at the behest of mostly physicians, also hospitals and other incumbent providers, to protect them and protect those sorts of schemes from market competition that would eliminate them. And we would never see them and never be having these discussions.
I love a good sprinkling of questioning clinical licensing at the end of a panel, but leaving that one alone, I think you got a full response, Dr. Porter.
Hi, my name is Mark Phillips. A few years ago, I got to see a similar presentation at another organization. They had a couple of representatives from the Surgery Center of Oklahoma. And for those of you who don't know, that's a physician-owned hospital, I believe in Oklahoma City. And it's designed for people that pay out-of-pocket, uninsured patients. And I was wondering, is there any similar facilities like a physician-owned hospital in Texas or any other states that are similar to the Surgery Center of Oklahoma?
There are. I understand there are some in Austin. Actually, it's funny. A lot of our surgeries for our employees are done at Surgery Center in Oklahoma. It's I live 14 miles from the the Oklahoma border. So, yeah, and they're great. But if you look at them, they're ethical. They do the pricing that David was talking about, the bundle pricing. It's like when you get a knee surgery, their pricing is with the medicine and with the PT, because that's what you want to know. You don't want 37 different bills when you get done. Like, what's it going to cost me, soup to nuts? And they know, and you don't. And I wish we had more of those. I do understand there's some in Austin. David, you might know.
Yeah, Texas Medical Management has grown gangbusters. They started in Austin. They used Keith Smith's model at Surgery Center of Oklahoma. Thank you for bringing them up, by the way. And they've moved into Houston. They're about to open up a facility in Dallas. There is a new hospital system that family something or other. I can't remember the name. I apologize to them if any of them are here or will be watching. But they're cash based, and we've seen that the work of Surgery Center of Oklahoma spur this kind of thing across the nation. Now, there's a lot of work to be done.
And there's a lot of perverse incentives to not do that if you're another hospital, because I can get $40,000 for the surgery that Surgery Center of Oklahoma is doing for $15,000.
Well, and people understand. It goes back to what we were saying, is that we're cash buyers. If you have a 5, 7, 10, and I've seen $15,000 deductibles, most 60% of Americans have less than $1,000 in their checking account. So that looks and feels like monopoly money. It's not something that looks feasible, and that's why they'll end up putting off care. And we're seeing more and more of that as a country. So, yeah, what they're doing revolutionized that space, and we're seeing momentum, and I'm very pleased to see that.
Yeah, and also in addition to that, it's not just like the ambulatory surgery centers or hospitals potentially going to cash pay. There's also a good number of physicians who are independent who left fee-for-service to become direct primary care physicians. I believe Dr. Porter, you're one. Usually it's a structure where you pay like a monthly subscription, and shockingly enough, when they do labs, it costs like $20 to do them. It's like commensurate with what's in your paycheck or your savings account. So there is a new breed of provider definitely arranging itself, and we'll see where it goes.
I think expanding direct primary care is one of the best things. If y'all hadn't checked into it, it's just a good payment model for your primary care. Currently, if you go to the doctor, they have 7 minutes for you, which means they've just got enough time to write you a script, send you to somebody, or send you to a specialist, where a direct primary care will spend as much time as needed because they don't want you back all the time. They actually want to address it because the financial incentive is aligned. And that's magic wand, better answer, magic wand, that the incentives would not be perverse. We have so many perverse incentives for the patient, for the hospitals, for the doctors. When we align those incentives, then doctors can practice medicine and patients can get the right care.
I do like that readjustment of your magic wand.
Yeah.
So
I get the magic on that.
okay, I'm going to switch over. Probably last question, by the way, that we're answering these questions.
Just wanted to see if the panel wanted to comment about the long list of coverage mandates that we have in Texas for fully insured plans.
Do not apply in the U.S. Virgin Islands. Do not apply. I don't know about Texas law. Generally, do not apply to short-term plans, Farm Bureau plans. Those are all exempt from that. But that's also protectionist in a lot of cases. Those laws are providers going to the legislature, doctors saying, require the insurance companies to cover my stuff because my stuff is essential, and taking away the consumer's ability to choose this. To choose coverage without that. And that's what the ACA or Obamacare does at the federal level. That's what the essential health benefits mandates are. And if you look at markets that are exempt from those regulations, like the short-term, so-called short-term limited duration insurance market, they offer plans that don't have coverage for uncomplicated deliveries because people don't want to buy that coverage. There are people out there who want to have coverage for complicated deliveries, but otherwise would want to pay for any deliveries out of pocket. And what those mandates do is take away that choice, drive up premiums, and increase the number of uninsured.
I think most people know that the mandates are adding cost, and I think that legislatively they keep happening because it happens incrementally. And when you have a standalone mandate that does something like require wigs for cancer survivors, who's going to vote against that if it actually gets through the process? It's a really tough political decision for people who are not in this issue to vote against. One of the possible tools to bring more data and evidence to the actual cost of this so that it's less of an emotional discussion and more of a rational discussion is actually having evaluation of mandates and seeing what it costs. There was a bill last session that would have done this. It would have created a mandate advisory committee that would have utilized data from our new all-payer claims database and basically come up with an evaluation of every health insurance mandate and what the actual cost of it would be so that legislators would be more informed to weigh those trade-offs. That's not a guarantee that mandates wouldn't happen, but you would probably have fewer of them if you had a more informed discussion of the cost versus the benefit.
And the last thing I probably want to add is something that I saw with the Texas Department of Insurance was there are some odd restrictions, even though you did an amazing job with HB 711 with anti-competitive contracting. But one thing I just noticed in statute and regulation was that there is still a lot of inability for PPOs and EPOs to actually scale the reimbursement based on quality, for effectively meaning that insurance companies cannot pay to a certain extent for healthcare based on its quality. So there's debate about that and still thinking that through, but I just noticed that that was an odd kind of potential holdback and also regulation posed on some insurers.
Yeah, I think it's been hard, if not impossible, even if you know the cost to vote against the wigs for cancer. I mean, that's going to get the votes every time. What we have been able to do essentially is come up with options and remove all the mandates. It's kind of funny. I always try. It's easier to start something new than it is to fix what's there. It's just really hard to undo. It's kind of like the insurance company. I think you're just going to have to kind of Uber the taxi market with the insurance company being the taxi market, and you're going to do something different. And it's all of that market is going to go, and the insurance companies will figure out how to participate. They're ridiculous. They have tons of money. They'll move over to that, but it's going to be a different market, and it won't look like insurance. It'll look more like direct primary care with direct, you know what I mean? It's going to look different. The market will do it if legislators stay out of the way. We just have trouble ever staying out of the way.
I think that about wraps us up. So before we thank our panelists for being here and taking time out of your day to talk with everyone, I'd like to give a shout out to the events team. You guys are awesome. We'd love to give them a round of applause. Putting this all together. Make sure to take care of the people that take care of you. And now, please thank all of our panelists for joining us today and giving us a rousing conversation to have. Awesome. I just said, Michael will be outside with some books that'll be awesome for you to talk about. Clinical licensing for the doctors in there might be an interesting conversation. Have a good one, y'all.